this is cultural and ethnic influences on drugs. Chapter 7, I know the syllabus says Chapter 9. That one's on nutrition. Clearly not anywhere in this. It's Chapter 7, though. So if you want to review, make sure you look into Chapter 7 and not Chapter 9. Alright, so once we had said before, pharmacokinetics is what's affected by cultural factors sometimes. So there's cultural factors you need to consider when you're prescribing. Here's a few of those things listed right here. So you want to make sure the factors are who in the family makes the healthcare decision, the patient's views on health and illness, and attitudes towards drugs and treatment. Several cultures only like folk-type remedies, holistic-type remedies, natural-type remedies, don't like drugs at all. People have different responses to pain. So once again, these are all the factors. These are the 3 factors that you need to consider when you're prescribing to different cultures and ethnic groups. Alright? Alright. So, ethnopharmacology, that's just the study of racial differences in drug metabolism. There's underlying genetic reasons for differences in efficacy, and they have found that the differences are because of hepatic metabolism across cultural lines. Okay. Cultural awareness. I think we've all learned this from our nursing, that you need to be culturally sensitive, and that doesn't change now that you're the provider. So then there's standards of cultural competency. These are quite a big thing. So everyone has to be, all professionals need to practice cultural competency, and that means following the national standards. Education and training of your staff usually have to either have an interpreter phone or professional interpreters come in. This is required by all organizations that receive federal funds. So if your institution receives any kind of federal funds whatsoever, you have to have this. And I'll give you an example. There is many Aunt Martha's clinics around, or Access, things like that, the VNA, they all get federal funds. They are required to have professional interpreters, or at least the interpreter line. I work in a private practice. We are not required to have that because we do not receive any federal funds. And they will remove your federal funds if they catch you not keeping up with your cultural competency. Okay. Let's see. And it has to be when you're, actually let's go back to the interpreter. Cannot use interpreters that are family members either. It has to be a professionally trained interpreter. Okay. Okay, so we'll start with the first group is African Americans. Many are uninsured. Many have poor access to care. They have this group has different beliefs sometimes, as all groups, to disease and illness. A lot of folk healers and folk medicine. I don't see that personally, so I'm not quite sure where this came from. Maybe some of you can help me with that. But according to the National Standards of Culturally Appropriate Services class in U.S. Office of Minority Health, where do the poor outcomes come from African Americans? What are they attributed to? So they believe they're attributed to health outcomes. The poor health outcomes are attributed to discrimination, cultural barriers, and access to care. I think that depends on what area you live in. This is the answer, and this is what you need to know for testing, of course, but let's just talk about that for a minute. If you have African Americans or Hispanic, we'll say them too, that group too, out in Aurora, there is poor access to care out there, and I agree with the poor health outcomes that are attributed to discrimination, cultural barriers, and access to care. Terrible access to care out there. To minority groups in Aurora. It's kind of a depressed area. It's semi-rural, so semi-urban. Now, if you go into the city of Chicago, we still have poor health outcomes, right? I don't attribute that to discrimination, cultural barriers, or access to care. Um, in the NICU, as a neonatal nurse practitioner, you always hear that, you have all these babies because of poor prenatal care. Wrong, wrong, wrong. Not always the case. In the city of Chicago, there is a free maternity clinic pretty much on every corner. Seriously, there is so much. Rarely, a matter of fact, in my days at U of I, do we get a mom in who's delivering without prenatal care. So I guess this statement is true and both false, depending on where you are. That's just an FYI. Just on a soapbox. So sorry. Anyway, okay, so let's move on. If I can get the mouse to work, as I posted before, I'm having some major computer problems. So racial difference in pharmacokinetics. Remember, pharmacokinetics is what you do with the drug. What your kin does with the drug. Pharmacodynamics is the drug does what the drug says it does, okay? So ACE inhibitors do not work well in African Americans, and why? They have less renin-dependent hypertension. Okay, so that's good to know, right? And the other thing too is they're the group that's most likely to have the adverse side effects to the angiotensin, the ACE inhibitors. So, with that being said, we need not to follow the exact guidelines. The JNC7 guidelines will tell you that we start with an ACE inhibitor usually. You can start with a thiazide diuretic for hypertension, but usually you start with an ACE inhibitor. So in the African American population, you are going to start with a thiazide. Okay, so let's see. We have American Indians. U.S. Indian Health Service provides no-cost comprehensive care to federally recognized tribes. 33% are uninsured. If anybody wants to relocate, there is a lot of jobs in Indian Health Service clinics. After this winter, everybody probably wants to relocate. Okay, so there is truly, I don't know that I would call them folk beliefs, but this is actually how they believe. They believe in spirits, healings, medicine bags, maybe worn it says, but they bring all their paraphernalia with them. They do believe in a supreme being. They think everything is out of balance if someone is sick. So there's little information on pharmacokinetics, once again, in American Indians, because once again, few studies have been done in this group for whatever reason. I'm not even sure why, because there's usually all studies are done on white adult males. I don't know if anybody's realized that, but that is the reason why we don't have a lot of information on Indians, American Indians. Asian Americans, Pacific Islanders, usually well insured, only 18% uninsured, usually employed. They have some different practices too, acupressure, acupuncture. Everybody's got something a little bit different. Okay, so a lot of Asians, and once again, not all Asians, and I guess all people are not created the same, right? We all have a little bit difference to us. So anyway, drug pharmacokinetics in response. This is cytochrome P450 isoenzyme 2D6. This activity is lower in Asians. Slower metabolisms of antidepressants and neuroepileptics may require lower doses. But, with that being said, would this be true for all Asians? No, because it's not, all Asians are not Pacific Islanders or Asian Americans, right? That says Asian Americans and Pacific Islanders. So this may be the case, but it is not across the board all Asians. This slide is kind of definitely one you need to pay attention to for the boards. I did have a board question with something about Asians and dehydrogenase deficiency. They have decreased alcohol metabolism. That's what that causes. East Asians, so that's East Asians or Eastern Indians actually, may be fast acetylators. They may require more frequent or higher dose of drug metabolized by acetylation. All Asians do not have the universal response. I'll say that again and again, and there must be a reason why I'm saying that again and again. Okay, Hispanic and Mexican. Okay, so you have Hispanic and Mexican, sorry about that. And here's just your demographic, 6.5 unemployment, healthcare utilization is pretty poor, 30% uninsured, and a lot still are illegal, not legal. They have native, they're healers called, whatever they're called, Caranduras. They use herbs and teas to treat illness. That's pretty much, you need to know what their native, you need to recognize what their native healer is called and how they treat illness. Okay. They don't always follow modern medicine whatsoever. Common illnesses, obesity, type 2 diabetes, and asthma in children. And I think that's pretty much, oh, that is it. Back to the Hispanic Mexican population and pretty much to American Indian population. Metabolic syndrome has just run rampant. They have no means to change their diet to a healthy diet either. They are sometimes the poorest of the poor. There's been such a hard time too with, I don't have any personal experience with American Indian, but I definitely have a lot of experience with Hispanic Mexicans that live in Aurora. And this certain population, supposedly a lot of them come from a certain part of Mexico. The obesity, the type 2 diabetes is just really terrible. And the gestational diabetes undiagnosed is terrible too. Just FYI, if you're ever taking care of, if you go to work for a federal clinic, you may see people prenatally. I believe one number on that glucose tolerance test prenatally is wrong. You need to consider them diabetic, and you need to try and intervene. I know we all think that in primary care we're not going to see pregnant women. That's not really true. We could all end up in a women's health clinic and do some prenatal care, early prenatal care, before 32 weeks, anything. So be cognizant that there's a lot of morbidities to babies that happen when moms are diabetic. So really, and I think the guidelines are changing now. It used to be 2 numbers on the glucose tolerance test when you were pregnant. You would be considered a gestational diabetic. Now it's 1, and it should probably be 1 number. So moms that are diabetic often have children, and it's called caudal regression. I've had babies without anuses. I've had babies without certain, with bowel obstructions, with cardiac defects, all types of things, missing limbs, and that's all from having diabetes during pregnancy that's uncontrolled. Anyway, but they all do believe, a lot of, especially from Mexico, Mexicans do use these native healers, and they think that some bad things have happened because of the evil eye. So, just an FYI, and that is pretty much it for this one.